Hello, hello. Good afternoon, Dr. E. Hang on one second. I'm just recording. Hello, ladies. Welcome. I'm just setting up my screen. Give me a sec. Um, Excellent. All right, we are rolling. Dr. E, thank you so much for being here today. How are you?
I'm good. I'm great. Thank you for having me. It's such an honor to be between you all in all your journeys and being a part of maybe getting some questions answered,
Yeah.
fine-tuning your journeys, understanding what you need to be thinking about with this
Yeah.
chronic pain that you have.
Yes, so thank you so much. So, hey, if we haven't met yet, I'd love to just briefly introduce myself and let Dr. introduce himself too. But I'm Kimberly. I'm a naturopath and clinical nutritionist. I've personally been journeying with endo for 26 years. And in the last 12 years, my journey towards, well, diagnoses of the trifecta that is your POTS, MCAS, EDS has come to light. Um, but I'm passionate about helping women with the complexities and the layered nature of these conditions. Oh, I see your little hand clap. Thanks, Mandy. Thanks for being here. So, yeah, it's just a pleasure to host you all. And we have Dr. E here who is also very passionate about our chronic pelvic pain journeys. Um, but I will let him introduce himself, and I'm just going to do a little note in the chat to remind you all that the chat is for us to use. Okay, so please pop your questions in here, and as we go and as we have our conversation, if questions come to mind, just put them in the chat, and we will go through them um, a little later. So thank you so much for that. And please keep your mics muted. They are automatically muted. Hello, Rachel. Um, but yeah, anyway. Hello, Caroline. All right, Dr. E, take it away.
Some familiar names there. Thanks, Kimberly. So, for those who don't know me, my name is Rayan Elkattah. I am an OBGYN. Haven't delivered babies in a very, very long time. I transitioned from training into fellowship in minimally invasive GYN surgery with a background of chronic pelvic pain. So that was our training, and the approach we have is primarily that of um, a wide angle of approach as opposed to just, yeah, it must be this diagnosis or that diagnosis. So I did that type of work with patients post fellowship in Illinois for 8 years. As a program director at the University of Illinois, I used to train young aspiring physicians to think about complexity and also train them surgically. And after that, transitioned into this more of a private practice, GYN concierge slash chronic pain management. And so um, I'm always learning and I'm always implementing and I'm always approaching this from a very wide angle. I've seen tons of patients. And I think it's fascinating to be able to do this with Kimberly and all of you. And the aspect from the perspective of I can't do my job to the best capacity without people who are helping me on the other side. So Kimberly is a simple example of that. But then also the PTs and the urogynecologists and the chronic pain specialists and the neurologists and it's immunologists. It's an endless list of people. It takes a village to get someone back to functionality. And so I'm humbled by your complexities and very passionate about helping women get better. So I'm
Yeah.
here. I've been in LA for a year and a half, and I've learned so much and I've explored so much and I've helped a lot of people. So thanks for having me.
Yeah, I mean, we certainly need more people like yourself in the medical space, in the conventional medical space, because as you know, endo is so complex and requires so much more than surgery and hormonal suppression, um, especially when we have other comorbidities in the picture. So thank you. Thank you for doing what you do. And
Absolutely.
In saying that, I'd love to hear more about your approach towards, the patient, how you guide the patient on their path to surgery and this concept of prehab that you implement in your practice.
Okay, so no preps were made into this discussion, so I'm just going to be very
Yes.
spontaneous.
Yeah.
Um, so why prehab? Because for someone to get to a point where they're in chronic pain and chronic suffering, and you can define that the way you want. And in the ACOG terms, the American College of OB/GYN, it's like 3 months or more of pain that's happening consistently. Whether it's cyclic or not, it's defined as chronic pain. So when you get to that state of experience, it's almost presumed that your nervous system has become overactive, upregulated, to the point that a normal stimulus may generate a painful response. And your experience is all translated inside of your central nervous system. So, which components are the brain and the spinal cord. A lot of the nerve processing happens at the level of the spinal cord, particularly pelvic triggers. And so your nervous system is upregulated, and then the effect on you ultimately is I feel pain and it progressively worsens when it's chronic. And so anytime there's chronicity, the classic statement I'm using with patients is anytime there's chronicity, there's complexity. And it's
Yeah.
literally an onion with multiple layers. And it could be as simple as a small shallot or as big as one of those big sweet onions that are massive and you've got even more layers. And so, how to get to the central portion of it is what prehab is all about. Unpeeling these layers, understanding their impact and their contribution. And um, it could be menstrual, bladder, pelvic floor, nerves in the pelvis, neurologic conditions, GI components, because a good chunk of the GI system is technically pelvic. Um,
Mm.
and the definition of pelvis is the umbilicus, so the belly button, all the way down to the pelvic floor. So pelvic pain is abdominal to some extent as well, so you can't disregard that aspect.
Yeah.
Muscles are not just your pelvis, it could be your abdominal wall, your glutes, your lower back. Do you have hypermobility as a confounding factor? These are like commonly misunderstood and not even looked at in the general world of pain management. And then you have to add to that their mental status. Like, where are these people in their mental health journeys
Yeah.
parallel to their pain journeys? Is there trauma, somatic, mental, emotional, physical, sexual? Everything adds into this bucket of pain, and the body keeps account, whether it's sexual trauma or even simple physical trauma. Um, and you won't understand the whole picture until you really do a deep dive into all these components. And then once you have this notion of what's going on, you take a step back and you target these multiple layers in a collective fashion. So that's holistic approach.
Yes.
We like to front load our journey with patients with Eastern medicine
Hmm.
and a little sprinkle of Western in that, aka the hormones. And if they're open to it, of course, and then work prospectively towards a goal of, I would like to get this much improvement with these symptoms in a window that spans anywhere between 6 to 8 weeks up to a whole year, if necessary.
Before surgery.
Before we surgically touch them, yes.
Yeah.
Now, some people have an expedited journey, meaning they've done so much prehab on their own. They come
Mhm.
in to us having done, for example, PT, acupuncture, and they are more on the spectrum of I just need relief. I've done all of this. I've capped, plateaued in my relief. I just want intervention. But the majority of people who enter into this um, tunnel, we go in with them. And we help them illuminate what this tunnel looks like by doing all these different components and reassess and touch base. Regular visits, 4 to 6 weeks. How are we doing now?
Hmm.
And I've had people get so much relief in 6 to 8 weeks. I've had people stay on this journey for up to a year. But the classic responses that we're seeing is relief, 10 to 60% response of relief by doing simple, non-invasive, multimodal, conservative, Eastern heavy interventions,
Hmm.
followed by surgery and then maintenance. And that's different for everyone. Everyone
Yes.
has a unique phenotype of symptom presentation, constellation of dysfunction,
Yeah.
which this treatment is tailored to their journey, and then we follow them. This is a short description of what prehab means.
Yeah, and I think the thing that's been highlighted to me as you're talking about that is just how personalized it can be and tailored it can be. And sometimes what's often lacking, I find, is that really thorough case taking to figure out what are the big things that would move the needle prior to surgery in a
Hmm.
patient. That's often, so often overlooked. I mean, thinking about my own journey in the conventional medical space, I feel like it's just the default path. I think the default pathway is to kind of just overlook that. So,
Yeah,
and I mean, everything that you've mentioned is so spot on. I think we could all agree that if we all had that or have access to that, perhaps things would be different. So yeah,
yeah. And,
that's
and then the bigger question to ask is, why is it this way? Why do we have to suffer for a decade before we figure out a place that can help us that navigation? And it all goes down to awareness. Like we're getting better at infusing more of this awareness into medical school and residency, but it's still so lacking. I still get patients who have ablations, and I still have patients who get sent to me who have had PT, but for Kegels. And
oh
it's
yeah,
it's like, okay, it's frustrating, but also very, very um, gratifying to be able to help someone after years and years of
yeah,
not getting there and no one
yeah.
listening. That's the biggest thing I hear. No one listens. No one hears me. I've been gaslit for years. I know these are all trendy terms these days, but it's not just trendy. It's the average
It is.
experience of patients across all disciplines, not just GYN. And so we're here to change that.
Yeah, it's so unfortunate. And like there isn't really much that we need to give as practitioners to be able to be a good listener. Like it doesn't take that much out of us to be a good listener. And there's so much therapeutic benefit in good listening. It's so, to me, it's just a no-brainer and it's so simple being on the receiving end of what you've described. So in context of what you've described about prehab, what do you then see that translate into the outcomes post-surgery if someone's done a solid prehab in the lead up to their surgery?
Okay, so I want to do a little tangential
Yeah, go
thought
for it.
here before I dive into that answer. What is prehab? How extensive can prehab be? So I'm just gonna give broad terms here, so not to go into fine detail. But
Okay.
here's a sampler of a prehab. Kind of like when you go order a sampler plate in a restaurant, they get you this big plate with all little mezes and stuff.
Yeah.
Here's what prehab may look like, and it's tailored to what we think the patient needs. So 100% of the time on that plate, you're gonna get PT.
Okay.
Everyone gets PT. And not any PT, it's designed for myofascial release and relaxation of the core and the pelvis. That
Yeah.
involves muscles, pelvis, and all kinds of muscle groups. Acupuncture,
Mm-hmm.
traditional Chinese medicine,
Mm-hmm.
cupping,
Mm-hmm.
moxibustion,
Mm-hmm.
Ayurveda,
Mm-hmm.
um, um, Topical, vaginal, or rectal cannabinoids.
Yeah.
There's evidence to suggest they can help also. Um, Nerve injections. If there's dermatomal involvements of specific pelvic nerves, see if that may be helpful.
Yeah.
Um, Pelvic floor Botox.
Mm-hmm.
Um, all types of psychotherapy, psychoanalysis,
Mm-hmm.
sexual therapy,
Mm-hmm.
somatic therapy for patients who have tremoring as an experience of pain. These are all linked in.
Yeah.
Um, and
All the nervous
then,
system work. Yeah.
yes, and then also functional medicine,
Mm-hmm.
like naturopaths, functional medicine, and under that, there's a very long list of tests that can be done,
Yeah.
and then Dutch testing, and microbiome, and zonulin, and leaky gut, and I can talk for hours about this, but
Yeah.
that's the bulk of it. Now, the sprinkle that comes into this is hormones, and when I talk about hormones with patients, it's a trial. It's not
Mm-hmm.
lifelong. It's not long term. It's a trial. Can we do this to lessen triggering from menstrual sources if it's endoadeno?
Mm-hmm.
And it's always a trial because I've yet to meet a patient who loves hormones. There's always side effects. No one likes it long term. But as a trial, it allows us to shorten that list of causes and fine-tune the surgical and post-surgical management if needed. So that's in a nutshell what that plate looks like.
Yeah.
So now to answer your question, um, what to expect with prehab? Improvement is going to happen. The question is how much of it will happen. And the response in prehab helps fine-tune the causes further. So, for example, you do PT for 6 to 8 weeks and you come back and you say, I feel 50% better.
Mm.
Well, that simply indicates that your muscles have been so tight and part of this pain experience that just PT alone has gotten you to that point.
Yeah.
Um, Now, in my experience, where I'm seeing the range of 10 to 60%. The peak that I've seen is around 85%. And that's the range of prehab that these patients have had to do range from 6 to 8 weeks up to 9 months.
Wow.
And then sadly, no one gets full relief. I've yet to see it, but I've had one patient, just one patient, who's had complete resolution. But they've had the full workups of MCAS and POTS, and they've done all these multimodal therapies, and now they're fully functional.
Wow.
But it's not, I think it's sad, but I don't think anyone can experience complete relief
Mm.
from this type of dysfunction because it's so complex. And any doctor who promises you full relief is a massive red flag. Just tread with caution when you hear that. I did forget to mention one component of the prehab,
Sure.
cleaning up your diet,
Oh, yes. Yes.
cleaning up your gut. Your gut houses 70% of your immune system. So when your system is jacked up, when the immune system is overactive along with nervous system, anything that goes in the gut that's not clean, anything that may trigger you, food
Mm-hmm.
sensitivities, processed foods, not organic, not whole, fully clean, with all the environmental toxins today.
Mm-hmm.
Gut health is core in optimization of functionality
Yeah.
and the whole journey from A all the way to Z and after.
Yes. Yeah, you're speaking my language for sure. Yeah.
Yeah.
And what if people come to you post excision, they've had successful surgery, all of the endo has been removed, no burning, cutting, no ablation, etc. And they're still dealing with chronic symptoms, um, as in chronic pelvic pain. I know one area that I'm seeing so much in my sort of patient demographic with the triad of the POTS, MCAS, EDS, or hypermobility spectrum disorder is like vascular compressions or pelvic congestion syndrome, and
Hmm.
that being a driver of chronic pelvic pain despite, excision and endo being completely removed because A, it's hard to visualize the veins when you're obviously having endo surgery, but also it's a whole other, it's a whole other beast of its own. I know there are
Yeah.
many other pathologies that can drive chronic pelvic pain post surgery, but um, I wanted to just park and talk about pelvic congestion for a bit if that's okay.
Yeah, yeah, of
Um,
course. This is where I always tell patients like we're gonna reassess your pain
yeah.
afterwards because it's that's my journey with you doesn't end at the 6 week post-op visit. That's where it actually starts. So because that's when we assess like how better are you and what's ongoing.
Mm,
And because a lot of people feel abandoned at 6 weeks because
yeah,
they feel
it's like, see
the
you
doc did my
later. Bye.
surgery and yeah,
You're
I'll see
healed.
you.
Don't you love
Thanks
that
for your
you're healed?
thanks for the payment and
Yeah,
yeah.
yeah.
But that's the
Oh,
chronic pain. That's the chronic pain, doc, and me talking at that point, okay?
yeah.
It's you get to the 6 week mark, great. That's your milestone, but how are you? What's
Yeah,
going on? And I commonly will go back to the examination table and
right.
feel again, is there anything triggering that I can actually reproduce? If not, that's when we have discussions about the exotics and the zebras that come
Mm,
with the syndrome extension of the endo. So, endo on the last endo summit, there's been a lot of discussion about classifying endo as a syndrome as opposed to
I feel like
as
it
an
absolutely is a
it
syndrome.
is, of course, it's a spectrum of a syndrome that's going on where endo is a part of it. And so the moment you understand the notion of syndrome, you'll be able to think outside the box and start assessing for the what I call them the zebras. But in patients with endo, they're more like the gazelles of the savannah. So they're more common than what you think they are, such as the triad that you work
Yeah,
with, MCAS,
yeah,
POTS, EDS, but also congestion. The venous congestion syndromes in the past, I'd say the past decade, have started to become more knowledgeable. In the past 2 years for me, so much talk about them.
yeah,
Um, Definition of venous congestion syndrome. So it's basically a condition where the veins, the venous tree in the pelvis or abdomen become dilated, contribute to less blood return to the heart, and may worsen symptoms because of their impact on nerves, vessels, muscles, and simply they pool with blood and they cause pressure as well. So pressure symptoms, heaviness symptoms in the pelvis need to make doctors think about congestion.
yeah,
If they compress nerves, and we're not talking about the known big nerves, we're talking about the autonomic nervous system, the
yeah.
hypogastric plexus, the celiac plexus, the nerves that control rest and digest, not
Hmm.
nerves that you manually like mentally control. For example, I want to move my leg, I'm going to send a message to the femoral nerve and
Yeah.
lift my leg. These are nerves that control organ function, visceral nerve function.
Yes.
So if you have veins that are congested, they will compress the nerve.
Hmm.
If it's the hypogastric nerve, it can affect your ability to lubricate during sex. It can
Mm,
affect your bladder function and cause urgency, incomplete emptying. It can lead to constipation. It can
mm,
cause, it can accentuate bloating. It can cause an endless list of symptoms that are considered vague,
mm,
unclear, not system specific.
mm.
And so when I see patients who have this vague symptoms, whether it's pre-surgery or post-excision, it triggers my brain into like maybe you have a congestion syndrome. The
Yep.
assessment is very basic. Get
Yeah.
an image. Get an
Yeah.
image.
Yeah.
Yes, it's expensive, but guess what? It's way more expensive if you don't figure it out early. Because you
Yeah.
might not need an excision
I say
if
this
you,
all the time. I say fixing a vein is so much easier, whether you need to like stent a Matherner or like embolize a gonadal vein that's large and reflux is so much easier than full-blown endoexcision surgery.
yeah. I
Yeah.
mean, it doesn't um, remove the need for the excision. I still
Yeah.
believe that
Yeah.
excising inflammatory tissue is very helpful.
100%.
But I've had numerous patients who you go in and yes, they have endo, but it's a little speck here and there. I
Mm.
don't think that explains the bigger picture, and they continue to have symptoms.
Mm.
Or they have a lot of endo, and you take it all out, and it was the most amazing excision of stage 4, and they're still in pain
Yes, I see that.
despite 2, 3 months of prehab. Like, what's going on there? I think it's very immature and reductionist to think that it must be central sensitization alone.
And that's almost condescending to the patient too.
It is, but
Yeah.
it also makes them feel hopeless.
Yeah.
And I refuse to think that it's that simple. So up until you rule out these exotic diagnoses and zebras,
Yeah.
you've not done your patients a service that's comprehensive. And again, this is the chronic pain in me talking, not the
Mm.
endo specialist.
Mm.
Um, Now, speaking about veins, when you go into surgery, for just to make this a little nerdy, not too much, but for the attendees, you can see a dilated vein during surgery, especially if that vein is compressed. But a lot of venous congestion syndromes don't have compression as the cause. And so
Mm.
when you're head down surgically, the blood in the veins comes out of those veins by gravity. It falls out of the vein. So you don't see a dilated vein most of the time during surgery for patients who have congestion syndrome.
Mm.
Um, the other factor that affects the veins is the the gas that we put in the abdomen compresses the veins. The pressure of the vein is around 12 millimeters, and the gas we put in is around 15. So almost invariably, the veins are compressed. You can't see them.
Mm.
They're not dilated. And so it's very difficult to diagnose a congestion syndrome on surgery
Mm.
unless there's definitive compression of a vein that leads to the blood fill in it, and that does not go away despite tilting head back and the pressure that we put in. And so that's why it's a hard thing to diagnose on a diagnostic scope. And so
Yep.
if you're suspecting it, get an image before and then do that. And then
Yeah.
assess for it, essentially.
Yeah. And just as a little comment there, the way that these pelvic venous disorders are dealt with from a vascular surgical perspective are sorry, wording, also non-invasive. So they'll go in either through your groin or your jugular, and they'll deal with the vein. So um, it's not like you will have to get a laparoscopy twice either, if you need to deal with the pelvic congestion. But it's very much worth doing extra imaging to rule out if this is you. And as I was saying to Dr. E earlier, almost every single patient I see who has endo and is hypermobile or has POTS, um, will have some degree of pelvic congestion, and which has typically been overlooked throughout their chronic pelvic pain journey. So it's important that um, that is addressed as well. If you are still dealing with symptoms despite a really good surgery, or like you said, small, tiny specks of endo, but you have these symptoms. Um, so, yeah.
Yeah,
So,
ask your doctor for an MRV, ask for a vascular assessment, refer to a vascular surgeon who can help you get the imaging done if you need it.
yes. And if you can't get the MRV or there's a wait, I know sometimes there's a bit of a wait, even just like vascular ultrasounds using a Doppler, it's very, um, like it's a very useful first stop as well. And then typically they may get you in to do a pelvic venogram,
Mhm.
which would then determine what your next steps would be if surgery is required. So yeah, you can do because I hear a lot of people say, they've got pelvic congestion, done all the PT in the world, and it's still really, really symptomatic. Um, that's probably because there's all this blood pooling and postural um, like postural deficits in the veins that's causing your symptoms. So definitely do the imaging and get that dealt with.
Yeah, and the responses are pretty impressive. Like there's so much relief of symptoms, whether it's pain, pressure, GI, bladder, sex. There's so much relief of symptoms that is, I mean, you're missing on it if you don't look at it. So I'm not saying that if you're in that position, you definitely have a congestion syndrome, but it's worth exploring. If you have vague symptoms that are lingering and pressure and heaviness, varicose veins may indicate that there's something in the veins as well. Um, I guess we're just instigating curiosity at this point for those who don't know much about this. Take a look at it, don't miss it.
Yeah. And I see Caroline's message. Yes, I was going to ask that. Was that about the veins during surgery? Feel free
Hear
to
me now?
comment. Yes.
You want me to unmute
Vein.
myself?
Yeah, yeah, unmute yourself.
Um, yeah, I think it was just a general question, because I know that I was talking to you about that, and I didn't know if that can sometimes be confused with endometriosis if patients come in with that, but he answered that question, and
Yeah,
maybe
I
maybe not.
also find, and Dr. E, I'd love to hear your take on this, but I find that the symptoms slightly differ to endometriosis symptoms as well. I find like there's a lot of postural symptoms, there's a lot of leg heaviness. It almost feels like and I mean, there's a little bit of overlap with adeno here where you feel like you're very like a bowling ball feeling in your uterus. Um,
Mhm.
there's all this. So if you have ovarian veins that are enlarged and the valves are broken, it means that the blood is not being effectively pushed back up to the heart and it's just pooling because of gravity. So if you just imagine a pathological amount of blood just sitting in your abdominal region, it's just not going to feel very nice. It's going to feel a bit throbby. You're going to also experience maybe even well, I see heavier and more painful periods with it too. Um,
Yeah.
and I had a
Another
vascular surgeon.
classic,
Sorry?
another classic feature is, and it's not diagnostic, but it makes us think more about it, is the pain gets worse by the end of the day.
Yep. The blood pooling for sure.
Exactly. And so they classically say, I wake up, I'm fine, and then by noon and afternoon, it's unbearable.
Yeah, and it feels better when you're like lying down and legs are lifted up. Like all these postural symptoms. Sitting down for a long time can cause the throbbing and the pain as well. Ovulation can feel intense if you've got like a gonadal vein that's, enlarged. I went through this just recently, so it's very fresh to me. But yeah, definitely seeing a lot more people um, with this. And can I ask you, Dr. E, if it is something that would be addressed in surgery? I have seen some surgeons ligate an agonadal vein during endo excision surgery. What's the thought around that? Because I
Yeah.
personally would think that the vascular approach would be safer with like coiling off a vein or using some sclerosant to shut it down.
Yeah, controversial, very controversial. So what Kimberly is alluding to is if you see a dilated vein, is it dilated because it's simply wide in itself, or is it compressed higher up in a place that you cannot see?
Yeah.
Because if it's compressed, you can relieve the compression like a stent in a vein, and that will help drainage improve. Um, And then there's other questions about does this, if I clamp a vessel or ligate meaning obliterate, block it, is there effects on the ovary if it
Mm,
can't drain blood properly? Poorly understood. I don't think there's a long-term effect, but it does have a transient effect in the
interesting.
ovarian health. So if you see, as a surgeon, if I'm seeing a dilated vein, I'm gonna note that, and I personally will not do much about it because if it's compressed, it may need a stent.
Mhm.
If it's not compressed, the interventional doc can literally block it with a coil or other means. But the intent there is, what if there's other veins that are affected?
Yes.
Let's look deeper into that. Now, some people will ligate. I don't think that's an unreasonable approach, but you still have to think about assessing for the venous congestion in that aspect and not simply be happy with, yeah, I saw a vein that was wide and I blocked it and it that wideness dissipated and that's all. I wouldn't stop there.
Yeah. Yeah, it could be risky. Could be very risky if there's
It's uncharted territory. There's not much science there. And so we as surgeons feel like we know better
Mm,
and it's okay to do XYZ. I prefer to inform patient about what I found
mm,
and educate them about the different ways to do this. I would not personally, I would not ligate or block a vein, even if I could. It's very easy, but there's risks and um, there's unstudied risks of that, and I would not experiment at this point, especially if the patients are on the younger side, because what if this affects their reserve of
yeah.
eggs and fertility, and it's too risky. I've seen multiple op reports from colleagues of mine who, for example, will block the blood vessels to the uterus because they think there's adenomyosis.
Like a
And
uterine
we,
artery embolization.
uh-huh.
Okay.
It's not embolization. It's more like during surgery,
Uh-huh.
finding the vessels and clipping them or burning them so that there's no
Oh.
flow as a way to lessen pain from the uterus. And Um, I mean, again, have we had those discussions with the patients? Is there any concern about fertility? It's
Mm,
it's uncharted. And so I just think that being aggressive enough is enough,
mm.
meaning excise the endo, get your images, get out, communicate your findings, continue the evaluation and assessment.
Wow, interesting. Really interesting about the uterine um, blood flow too, in the context of adeno. Um, can I ask you a few questions that have come up in the chat, if that's okay?
Yeah,
Um,
I'm looking at them here
oh,
too.
you
Yeah,
can see
go
them
for it.
too. Yeah, Vivian's asking about lipedema with heaviness in the leg. Can it be linked to pelvic congestion? I personally don't know enough about lipedema to be totally honest with you, but it's
Is it
valid.
lymphedema?
Yeah.
Are they referring to lymphedema?
Vivian,
Vivian.
feel free to.
I think you're referring to lymphedema. Lipedema. I don't know.
Yeah,
I've
I don't
never
know.
heard this term before. Um, I would have to search that and get back with you
Yeah, it's the
through
inflammation. And
Kimberly.
I know that yeah, inflammation of fat. Um I know there's still a degree of lymphatic congestion, and if you have obviously if you have pelvic congestion, it would worsen it, but I do believe it's separate. I don't know if there's a link there. So I'll have to research that too, actually. Thank you. Sorry, I can't give you more than that.
We'll get back with you on that one
Yeah.
because again, we're all learning here. We're all
Yeah.
figuring out all these different components. So I'll definitely check into it.
Yeah, and Prasanthi, questions about adhesions. So after endoexcision surgery, I developed adhesions where my ovaries are sticking to the back abdominal wall, giving me severe flank pain and hip pain. Developed endocysts within 3 months after surgery. Okay, Dr. E, take it away.
Adhesions where the ovaries are sticking to the abdominal wall. Wow. That's very high. The classic adhesions of ovaries happen in the pelvis. So, um, technically, to lessen your pain, you need to have them released. There's no, I mean, so there's no sensory representation of the ovary in our brains, but the tissues around the ovaries have nerve endings.
What
So
exact? Sorry, can
I
you
will
repeat that?
explain that. I will
Yeah.
explain that. So
Sure.
there's no sensory representation of the ovaries on the sensory homunculus, meaning there's no nerves on the ovary, but there's nerves on the tissues around the ovary. So
Got it.
referred ovarian pain, when
Uh-huh.
when someone tells me I have pain, ovarian pain, it's
Yeah.
referred peri-ovarian pain around the ovary. So if an ovary is stuck,
Right.
it
It's
will refer to its original pathway where it started off when you guys were all embryos. So the ovary starts in the back where the kidneys are, and it
mm-hmm,
migrates to the front down to the pelvis.
mm-hmm,
So flank pain from a stuck ovary should resolve if you free that ovary up. Now think about an ovary that is stuck. Anytime a cyst forms in it, it's gonna grow and it's gonna pull on that ovary. So the tissues around that ovary are going to feel it, and it refers along those pathways. So my thoughts, you can try to do deep myofascial visceral releases. If those don't work, consider an actual lysis of ovarian adhesion, meaning surgically go in, free up the ovary, probably use some type of adhesion barriers to limit the risk of re-stickiness and confirm that the stickiness wasn't caused because of endo that's left
mm-hmm.
behind, causing inflammation and stickiness. Those are my thoughts there. But obviously, it's complex, so you need to do an exam as well.
It's very sad, this is 3 months post-op. It's like having to think about going back in under the knife to release those adhesions. It's hard.
But this early, um, Prasanti, this early, if you're not debilitated, it's worth to do multimodal and
Mm,
lessen the sensation of pain because, I mean, you might not need surgery, but it's hard to tell. May consider a hormonal trial just to see if that lessens the pain, because if it does, then it means more endo related, um, as
Are you
opposed to
talking about
adhesion based.
progesterone?
Yeah, that would be a reasonable option.
Yeah. Wow. What would be the biggest thing that would cause an ovary to stick up? Because that's back. That's like up and high, up in the
It's
abdominal
too
wall.
high. It's too
So
high.
yeah, what would be?
Um, Thoughts that come to my mind. What kind of endo was it? Was it advanced endo? Was there endo on the abdominal wall?
Mm,
Um, how much heat was used during surgery? Heat
yeah,
damages tissues, and so any surface that gets devitalized, your body's response is to cover it up. Shield it. Shield your normal tissues from dead tissue. Dead meaning
right.
overcooked, burnt tissue. So if there
Yeah,
was a lot of heat involved and the surface of the ovary potentially is burnt or the surroundings, it can get stuck to anything.
yeah.
Bowels, abdominal wall, uterus, pelvic sidewall.
And it was
It's
stage
very
4 TI,
tricky.
so that makes a difference too.
Yeah. And it's not unusual for stage fours to need what we call a revision second surgery after the initial debulking because there's sometimes so much disease that you can't physically remove all of it because everything's swollen, everything's bruised, everything looks inflamed. You don't know where endo and normal tissue ends. And so you remove what you can, and it's not unusual to go back in for a revision second look to fine tune the final excision and liberate the tissues that are inflamed. Um,
Why?
so
Great.
yeah.
Thank you. Kathy has a question about what about removing uterine varicose veins during hysterectomy for adenomyosis, postmenopausal on HRT? I don't know much about hysterectomies, I have to admit. So,
Let me just read it. What about removing uterine
Kathy,
varicose
yeah.
veins during hysterectomy for adeno? So it's presumed that when you do a hysterectomy, the veins of the uterus are coming out,
Mm,
unless you're talking about what's left behind. So if there are true congestion syndromes, the flow into those veins goes down from the hysterectomy. So that portion of surgery resolves those congested veins, not the others.
yeah, you'd
So
still
you
need
still have sacral veins, deep iliac veins. They're still present and they're still going to be dilated with a hysterectomy.
yeah, yeah. So do you often see uterine varicose veins in when you do hysterectomy? Would that be a sign of pelvic congestion?
Definitely
Yeah. So
raises the flag, of
yeah,
course. Yeah.
yeah. So Kathy, maybe look at doing a like MRV or Doppler and then venogram. Um,
Especially if your symptoms are still there.
yes, yeah. Okay, Rachel, should you request any specific drugs or histamine blockers during after surgery while in the hospital to prevent MCAS flares from endoexcision? Oh,
Yeah, that's a great
interesting.
question. Yeah. So the ones I've used to very effective means sometimes part of the enhanced recovery after surgery protocol for me is Celebrex, Tylenol, gabapentin, giving them a bunch of medicines before they go in to prime their nerves, calm down their nerves, and then a nerve block during surgery. But for the MCAS patients, pre-op cromolyn is an
Mm,
option. Yep,
interesting.
like liquid form, pre-op, usually an hour before. And post-op, anything, either cromolyn, hydroxyzine, or Benadryl.
Yeah.
It's a very reasonable, safe option for them. So yes, I don't have a specific. I ask the patients what has worked for you, and usually we'll stick with that. If they don't have a preference, I'll classically do cromolyn post-op.
In a oral liquid?
Yeah.
Nice. Okay. That's interesting. Um, that what did you say? Hydroxyzine and what was the other one?
So either cromolyn, hydroxyzine, or Benadryl.
Right. Okay, got that.
And antihistamine. Some people will also add Pepsid before the case. There's
Yeah.
just so many ways to calm down the
Yeah.
histamine release.
Does this ever go into the like, is this after? Did you say you give them antihistamines before as well? IV?
No, none of that's IV. It's the cromolyn
Oral.
is oral. The
Yeah.
cromolyn's oral. Benadryl can be IV, PO,
Yeah.
oral, and hydroxyzine is typically oral.
Yeah. Okay. Very cool. And what about like a H1, like you mentioned famotidine Pepsid, but what about like a Zyrtec or a Claritine or something like that as well? Would you add that into the
Mm,
mix?
mm. I would add whatever the patient has tried primarily and works for them.
Yeah.
Because if it's shown to help them, there's
Yeah.
no reason to do something different. But yeah,
Yeah.
we account for it.
Yeah. Yeah. Okay, cool. That's good to know. Um, excellent. Have a question here about progesterone. Um, have you ever seen a link with bioidentical progesterone worsening pain and symptoms in any endo patients?
That's a good question. I have not in my clinical practice. I have heard from other docs that this can happen because endo, while most of it responds to progesterone, some of it is stimulated by it too. Endo has estrogen and progesterone receptors, and not always is the response suppression. So I tread very carefully with bioidentical. I think there's so much room for it, so much room, because it seems that the side effects are less than synthetics, and you can play with the doses so much. And so for me, the range on the bioidenticals goes as low as 50 milligrams and as high as 300. And I
Mm-hmm.
play with it with patients, meaning I sometimes will do it full month, sometimes luteal phase through post cycling, sometimes during cycle. Everyone's so sensitive and different. So we talk about effects, benefits, pros, cons, and we tailor the treatment to what we think is going to work best for them. I haven't seen worsening with it, But if there is worsening, the other question to ask is, what are the side effects of progesterone that can cause worsening of pain? That's not endo. Progesterone is a vasodilator and a
Mhm.
muscle relaxer. So
Mhm.
you need to start thinking also about these congestions,
Yes.
about
Constant.
bowel related,
Yeah.
IBS related, constipation, bladder relaxation to the
Mhm.
point that you might have urgency because it's filling up beyond its capacity, incomplete emptying of the bladder. It's it's so tricky when you have worsening symptoms, it's so tricky to presume that this is the cause. It might be the side effect of as opposed to the cause. And
Yes.
so revise the symptoms, look back into all the symptoms and no, don't presume is
Yeah.
what I'm saying here.
Yeah. Yeah. I have, and just on a note, it also depends on the form. I find that oral progesterone, because it goes through first pass, it goes through your gut and your liver. You get different side effects to like vaginal or transdermal progesterone as well. So it really needs to be fine-tuned with your prescriber. Yeah,
Kimberly, do you do topical progesterone for your patients?
predominantly, yeah, because that doesn't
Prometrium?
require. For me, I can't write scripts, so unless they have another provider who's willing to trial Prometrium with them, we usually always go to just use a topical bioidentical. Sometimes I get patients, they get like a troche compounded as well.
Mm-hmm.
It just depends on what they can tolerate, really, and we find the right. It's a lot of trial and error.
Yeah, yeah, I agree.
Um,
For me, it's always a trial. To also to reiterate, any hormone is a trial for me. And if
yeah,
it really works well, we talk about long term.
yeah, yeah. Oh, we've got a few more questions here to get through before we wrap up. Prasanthi said she went through discoid anastomosis.
Discoid means the endo was essentially eating into the wall of the colon, not full
Oh,
thickness. Or actually it may be full thickness. So they removed it. It's like a patch on
mhm.
a cylindrical pipe. A patch was removed and then they closed it with a suture. By definition, that's very aggressive endo.
Yeah,
So I think it's worth doing some multimodal and then revisiting with a potential revision second look because there's almost always residual endo in the stage fours. It's very hard.
yeah, it's so hard. It can be so hard. Rachel, thanks for your sweet message. You said thank you, Dr. E, for your kindness and sincerity. You care much. Skill and all your aftercare is rare and appreciated. So fun you've connected with Kimberly. She's so great as well. Just a shout out. Oh, thank you,
Thank
Rachel.
you,
Appreciate
Rachel. It's been a pleasure to take care of you.
it.
Um,
Lakeisha.
Lakeisha, it's a good question here. So specific states. I don't have any specific names. I just have one connection who I have entrusted the care of my patients to, and it's Dr. Brooke Spencer out in Colorado, the MIPS Center, um, for congestion specifically.
Yeah.
Um,
Feel free to
and
reach out to me as well. I could probably give you some other.
yeah, I'm sure Kimberly has a lot of contacts there. Kathy, PCS identified on MRI.
Yes.
What's
And I'm
PC?
like,
Polycystic ovaries? Is that
oh,
what
pelvic
PCS stands?
congestion syndrome identified on
Oh, okay,
MRI.
okay.
And I'm awaiting hysterectomy, worried I should have vascular workup before hysterectomy.
Um, so Kathy, if you have classic just pelvic congestion, which is like the bread and butter of most of these, you will get better with a hysterectomy. But I mean, in my line of work, I think it's very helpful to get as much info so
Yes.
that you can make informed decisions. So
Yes.
I think you should consider that. Yeah.
Yeah. Um, Definitely. And do you know what was identified? Was it like your ovarian veins that were enlarged and refluxing? It would be interesting because it'd be interesting to know. Obviously, I don't know why you're getting hysterectomy, but it would be interesting to know if the symptoms that you describe are like more congestion versus why. I don't know why you're getting the hysterectomy, but if it is more vascular, then yeah, definitely consider getting that workup. Um, I had a different surgery, Caroline. I had a different surgery last October. I took some supplements that helped too, quercetin, etc. Those okay alongside. Yeah, so those are mast cell stabilizers. Are you talking about for endo surgery or just in general?
No,
Um,
just like a separate surgery, because I was really worried about that after my surgery. It was breathing surgery, and I was worried about mast cell
Oh, you're
flares.
talking about because someone asked a question earlier about mast cell stabilizers. Yes, yeah. I mean, you if those are the mast cell stabilizers that work well for you, I still say stop everything like a week out. I don't know, Dr. E, do you recommend
Same.
stop all supplement? Yeah, yeah, just to be safe, and then you can restart them afterwards as well because there are also interactions, drug herb, drug nutrient interactions that we want to avoid, especially if you need to take a cocktail of things to recover. So
And
that's
you
my,
can also ask your doc to do a deep dive on interactions and fine-tune what you may continue versus not. I've done that.
that's so neat.
And most of the time, the supplements, most of the time, there's interaction with anesthesia and
Mhm.
there's an increased bleeding risk
Yes.
most of the time. So when you look at the bigger picture, most of the time we recommend stopping them at 7, sometimes up to 14 days early. But I have continued some that don't have interactions because why not? And it's really tailored to patient by patient. But in general, yeah, we stop them.
Yeah. Yeah, for sure. And also, Caroline, something that I do with pre and post-op is homeopathics, which are not going to interact with anesthesia or cause bleeding risk. Okay, let me have a look. Brittany, when struggling with all these issues, which is the best to look at first, and what specialists for MCAS, pelvic congestion, endo gut issues, naturopathy? Well, um, I always try and look at what's your dominant issue when we're looking at MCAS, pelvic congestion, endo. There's always going to be obviously there's a large immunological component, right? So, um, maybe I'm just a little bit biased, Dr. E. Maybe I'm biased because I always look at the patient like as a whole person, and I go, okay, well, what is the thing that's preventing you from, you know, moving, living, eating, like getting by your day to day, meeting your needs, and then going from there.
I
But
defer to
absolutely,
you, Kimberly.
pardon?
I totally defer to you. Totally defer to you on this one. I don't think there's a sequence. All of it, all of it together. It's a lot. It's overwhelming, but you have to start somewhere.
Yeah. Yes, and often they're like the multimodality approach, right? You want someone that can address your pelvic floor and your immune system and your digestion. And there's such a big link between them all, especially when you have something like mast cell activation syndrome in the picture. It's going to cause such a ex I don't like using the word exaggerated, but everything is going to be so enhanced. Like your gut issues are going to be worse, your endo symptoms are going to be worse. So if someone has MCAS, I'm always like, okay, what can we do to stabilize those mast cells? And that will include like nervous system work, cleaning up your diet, um, reducing toxins, et cetera, and mast cell stabilizing medication and H1, H2 blockers most likely. But yeah, you kind of have to see what's going to move the needle for you. And if you've got MCAS, dampening that histamine response and mast cell degranulation will usually have a flow-on effect to everything else, including your gut, endo symptoms, etc. Um, did you have anything to add there, Dr. E?
No, not at all.
Okay.
It's really multimodal, but start
Yes.
with what you can and build on it.
Yes. Okay. We have to wrap up shortly, but I might just do a couple more. Okay,
So
Vivian,
Vivian had a question, which is very
looking
interesting,
for.
and I think I can guide you here, Vivian. So, in short, you have advanced endo. Good for you on doing all the prehab, acupuncture,
Yes.
Chinese herbs.
Mm,
That's great. The 6 centimeter lesion is a big one, and the
mm,
an to answer shaving versus resection. If the circumference, so the circumference of the sigmoid is more than 50% involved,
Mhm.
a disc shave or disc resection is not appropriate. You would have to have cut the whole segment out and reconnect them for the optimal results. If you have a shave and they
Mm.
repair it with a stitch, it may narrow down your colon and stricture, which causes a lot of pain with bowel movements. Um, so revisit that with your doc and just ask them what circumference of my colon is involved, how much of it. So if this is the whole circle of the gut, if it's more than half of that circle, a full resection is better than a disc or a shave. Now, it could be 6 centimeters long and superficial. That's different. You can do a disc, you can do a shave because you'll still have plenty of tissue to have a normal caliber once the repair is done. Just clarify with them.
That's yeah, that's significant. And also, would you require the involvement of a colorectal surgeon or
I do. I personally, so I do my shaves, I do my discoids, but whenever there's advanced disease, I like to have a colorectal with me because I don't operate on the bowel every day.
Mhm.
They do, and the outcomes are better. So, um, I do. I do have them, but some endosurgeons do it all. I know people who do full resections and anastomoses, and I have not been trained in those, so I personally don't.
Yeah, yeah, and it sounds like this is quite advanced, like you said, 6 centimeters. So what is the typical diameter of a colon?
Um, if it's distended, it could be as wide as 5 centimeters and sometimes even more. But usually when it's not distended, I think it's around an inch and a little
Okay.
over an inch. So it's
So
not
it's
too
big.
much.
So this is big in the context of the size of her colon, this 6 centimeter lesion.
Yeah, but it's all relative. Like
Mhm.
6 centimeters means nothing to me because I need the three-dimensional structure of this lesion.
Right.
Because if it's a 6 centimeter long, questionable lesion versus focal nodule that's deep, that differs.
Yeah, of course, of course. Kind of like the lady who talked about her bowel DIE earlier.
Hmm. Yeah.
All right, I think that that is it. Brittany, I just commented on your question about who prescribes the MCAS medication, regular GP or specialist, both. And there are things you can get over the counter. There are non-pharma mast cell stabilizers and antihistamines we can trial too. Um, Amazing. Was there anything else that you wanted to add before we wrap up, Dr. E?
I don't know, that's going to be poetic, but you are your best advocate.
Yes.
Educate yourself, learn about this, invest in your health. There are people who care out there. You just have to find them and make sure you find people who have alignment with your values
Yes.
and who listen. Then you'll be just fine when you get to that point. And be patient. We're teaching a lot of people about this. So I think we'll all be in a better situation in a decade from now. But until that happens, advocate for yourself because there's not enough, there's just not enough advocacy. We can only do so much, and this is one way. But yeah, that's my parting message for you all.
And there is so much information online now. I mean, like this is why we've done this, is to literally provide information to you and help you make more informed decisions about your health and become informed and educate. So thank you so much for being here. Find your people. Like Dr. E said, find your people. There are people out there. There are options. It breaks my heart when a woman thinks that all she has access to if she has endo is surgery, and we don't even know what kind of surgery. and hormonal suppression, there are options. So I hope this has ignited some hope in your health journeys, and I hope this has been useful. Thank you so much for all your kind thank yous and messages in the chat. If you can, Dr. E, can you just let everyone know where they can find you if they would like to consult with you?
Yes, of course. So I just sent on the chat box where you guys can find more info on us, keeping it simple. It's iriswings.com.
Yes.
Um, I'm part of this practice and I'm very passionate about what I do. You'll be heard. You won't
Yeah.
be left alone. You won't be abandoned. I'm there. I'm here for you, and I love what I do.
Yeah, and we can definitely tell, which is awesome. And also, unfortunately, Dr. E is not on socials, but hopefully I can drag him into more of these events and, focus. I know that there's, so much interest on certain medications and um, medications that are starting to be used in the endo space that I'd love to pick your brain about as well. So perhaps we need to do more sessions on
Yeah,
these
we can do a
topics.
session on the atypical compounded stuff and
Yes, like your LDNs and your GLP.
oh yeah, LDN,
Peptide.
GLP, Journavx, all kinds of good stuff.
Yeah, I'd love that. I'd love that because I think we need to realize that we have more at our fingertips than we realize. But thank you so much for being here. Thank you so much for making the time, Dr. E. It's so appreciated. And ladies, just thank you and look after yourselves.
Thanks, Kimberly. Have a
Same.
great afternoon, morning, wherever you are. Take care,
Yes.
everyone.
Thank you. Bye-bye.